All right. Okay, let's get started. So good afternoon, everyone, and welcome. My name is Super Chansko. I'll be your moderator for this session, which I'm hoping is going to be a really exciting hour. I am the CEO and one of the co-founders of HepB Companion here in the UK. We are a patient advocacy group. And thank you for joining us for this post-EASL 2026 webinar, but also just a clinical update around hepatitis B and hepatitis D treatments. So this year, the Congress EASL in Barcelona was really exciting. We've seen huge developments in the hepatitis B field, which arguably can say that has been quite stagnant for the last 10 years. And we have two world-leading experts to bring us through the data that really matters. Oh, there is a strong echo. One moment. I'm gonna turn my volume down. Okay. Sengi, I'm just gonna mute you for a second. Okay. Catherine, is that better? No. Okay. Not sure what I can do. Oh, Catherine, you're signed on with two different accounts. It might be that. Okay. All right, let me continue. So, before I introduce our speakers, there is a few housekeeping notes. So this session is being recorded and will be made available after the event. There is a Q&A box, so feel free to ask any questions through there, but there'll be dedicated time to ask some questions. And I'll be keeping an eye on your questions as they come in. And for anyone from our colleagues at the British Viral Hepatitis Group, the BVHG community, very warm welcome today. And thank you for joining us. So whether you are a clinician, researcher, or someone living with hepatitis B or D. Now, to our speakers. Firstly, we have Professor Patrick Kennedy. Patrick is a consultant hepatologist and gastroenterologist at Barts Health NHS Trust and a clinical professor in translational hepatology at Queen's Mary University of London. He is internationally recognized research focused on the translational aspect of hepatitis B, and he leads both the hepatitis B clinical service and the young adults hepatology service at the Royal London Hospital. And second, we have Professor Seng Lim. Sengi is a senior consultant and director of hepatology at the National Uni of Singapore, so NUS, and a professor at the Yong-Lu Lin School of Medicine with over 250 peer-reviewed publications and a H index of 51. He is one of the foremost global authorities on chronic hepatitis B and a regular invited speaker at AASLD, EASL, and APASL. Patrick, Sengi, really wonderful to have you both here, and thank you for giving your time.
So thank you very much, Super and Patrick, for inviting me to participate in this webinar. I'm very excited to be here and share with you some of the recent data from EASL. So I'm going to have a few slides just to set the scene. These are my disclosures. And I think the first thing I want to do, because I don't know whether your community are really knowledgeable about hepatitis B or not. So I'm going to give a bit of background information. First of all, what is the objective of hepatitis B treatment? And the current goal of treatment is something called cure, which we call functional cure, where the S antigen is negative in the blood and HBV DNA, or the viral load, is also undetectable. And you need to be off treatment for at least 6 months in order to achieve this objective. Now, why is this important? I think I've shown one slide here showing that from Hong Kong of a few thousand patients, where patients who were not completely suppressed were worse off than the patients who had complete viral suppression with antiviral agents. But the risk of liver cancer was still 5.6% in those patients. But if they'd lost S antigen and had DNA suppression or no detectable DNA, the risk of liver cancer was much, much lower. In fact, it was 76% lower risk of liver cancer compared to patients who are S antigen positive on antiviral therapy. Now, how easy is it to achieve S antigen loss and functional cure? It's been very challenging with current therapies. And this is a rather complicated slide telling us that there are different strategies that are being tested in order to clear hepatitis B and achieve functional cure. This includes the current therapies to inhibit replication, which includes mainly nucleoside analogs, and the strategies to lower the viral antigen burden, which is mainly the S antigen, includes transcriptional inhibitors and translation inhibitors, amongst other things. And the other strategy is to boost immune responses. And the key for this has been interferons, but other mechanisms are being tested, such as therapeutic vaccines. However, today I'm really going to focus on transcriptional inhibitors, which leads me to the key study that was presented at EASL. The first study, and this is a landmark study, where it showed clinically meaningful rates of functional cure in virologically suppressed patients with chronic hepatitis B infection treated with bepirovisen. And this is the first phase 3 trial that is being tested for functional cure. So what is bepirovisen and how does it work? So bepirovisen is an antisense oligonucleotide. And this basically is an RNA, DNA mixture of drugs or molecules that is injected subcutaneously for 24 weeks. It's a weekly injection. And how does it work? It has various mechanisms of action. It does suppress virus replication. It also reduces the S antigen production. And it also has an ability to stimulate immune responses to clear infected hepatocytes. And this leads to this functional cure state. So this is a key finding of the phase 3 trial for bepirovisen that was presented at EASL. And the functional cure rate in patients with an S antigen at baseline of less than 3,000 was 19% compared to the placebo. And the placebo means that these patients are actually taking nucleoside analogs. They're not taking no treatment. So none of the patients who are taking nucleoside analogs actually got functional cure. Now, if your S antigen level was actually less than 1,000, the functional cure rate was 26%. At the same time, the patients who were on placebo or who were taking nucleoside analogs did not achieve functional cure at all. So this is a really landmark finding. It's the first drug that is shown to have such high functional cure rates. What else should you know about bepirovisen? Well, it does have some side effects. And the main side effects here are injection site reactions. This includes redness or erythema, pain, pruritus or itching, and bruising. There's also evidence of AST and ALT increase, some fever called pyrexia, a reduction in platelet count, and some patients get headaches and upper respiratory tract infections. But if you notice, the patients with headaches and upper respiratory tract infections were similar in the placebo group. So they're probably unrelated to the effects of bepirovisen. Now, other important findings are that patients had to stop treatment because of side effects. 4 patients out of 1,200 patients had to stop treatment due to a high ALT or liver inflammation, and 8 patients had to stop due to a low platelet count. However, I should emphasize that there were no deaths, there was no bleeding, there's no liver failure due to bepirovisen treatment. And this bepirovisen belongs to this antisense oligonucleotide class of agents, which are known to have transient side effects, such as a reduction in platelet count and effect on kidney function, which resolves after stopping therapy. So in summary, bepirovisen is considered to have an acceptable safety profile. What else should you know about bepirovisen? First of all, it's an injection, and it comes frozen and refrigerated, and it needs some time to defrost. It's given subcutaneously, and preferably it's given in the abdominal region. The duration of treatment is 24 weeks, and is weekly injections. And the 2 loading doses means that the first 2 weeks, patients need to come twice a week for the first 2 weeks. During therapy, you will need monitoring for your platelet count, your liver function test, and your kidney function. And you'll need to continue oral tablets during bepirovisen treatment. You can only stop when you're advised by your doctor. So to conclude, and I'll be happy to take questions after this, the phase 3 results show the best outcome of functional cure, which is S antigen negative and DNA negative of therapy, can be achieved in up to 26% of patients with chronic hepatitis B who have levels of S antigen less than 1,000 when they start therapy. Most side effects are related to injection site reactions, and they're not really too serious. The study will change the landscape of hepatitis B treatment and make hepatitis B cure a reality for a lot of patients. Bepirovisen is expected to be approved by the end of this year or early next year. And with that, I'll be happy to take questions and answer any issues. Thank you for your attention.
Thank you so much, Sengi. That was a brilliant summary. So a 19 to 26%, depending on surface antigen level versus placebo from a phase 3 trial, which is great because currently I think the literature says that, some literature say that if you have been on a hepatitis B antiviral for 10 years plus, there might be a 1% chance of seroconversion. So that's really great to hear. And it's so significant because we've never really had anything like this in the hepatitis B field before. So I'll give people some time to put in some questions into the Q&A, but I can get off started with a couple of questions. So one of the key things I've noticed as a patient, someone living with hepatitis B myself, for Bepi, who would be administrating the medication? Would it be ourselves or would it be the healthcare practitioner in this case?
At the moment, it is expected to be given by a practitioner or nurse. I think there is a move to try and make it more friendly so that patients can start to use it like interferon. But at the minute, I don't think that is actually been approved yet.
Okay, thank you. So there is a question here from Chirag, but it is related to hepatitis D. So I will, if it's okay, Chirag, I will keep this question for after the next section when we talk about hepatitis D. Okay, we have one from Teresa. I'd like to ask how high were the ALTs and AST flares with Bepi?
Okay, so overall, I think around 50% of patients had that abnormal ALT. And if your patients with ALT more than 3 times upper limit of normal occurred in about 23% of patients. 10 times upper limit of normal occurred in about 8% of patients. Now, we should remember that ALT, although it's considered a safety measure, it's actually an efficacy measure as well. Efficacy meaning that if your ALT was more than 3 times upper limit of normal, you have an 80% chance of getting S loss. But if your ALT was less than 3 times upper limit of normal, your chance of S loss was less than 20%. So no patients actually developed liver failure. Out of the 4 patients who had to stop treatment because of a very high ALT, 2 of them actually lost S antigen and had functional cure. So actually, a high ALT is actually a good thing because it tells you it's working and you're likely to clear the virus. So I think the first thing is that you shouldn't panic about the ALT. And should you stop treatment? I think if you develop jaundice, yes, you should stop treatment. But if you don't develop jaundice, I think you should just monitor the situation. There is a strategy to withhold treatment or pause treatment and monitor, and then restart it again if the ALT comes down. So I think your attending physician can guide you on the strategy to do that. But generally, high ALT is a good thing, not rather than a bad thing.
Thank you for that, Seng. So we have a question here from Oscar. When counseling patients with low hepatitis B surface antigen, what kind of likelihood do you quote for functional cure with bepi?
Well, the only data we have is the one I've shown you here. There's less than 1,000. It's about 26% possibility of functional cure. I think if your S antigen is between 1,000 and 3,000, your chance of functional cure is actually only 7%. So I think most people, including myself, will be recommending therapy for patients below 1,000 rather than below 3,000.
Thank you. And I guess one last question for me for this section. So as you can imagine, and Patrick, feel free to chime in on this as well. As you can imagine, this bepi has a FDA expected approval date of the 26th of October this year. So it's very, very soon that we might be seeing this this treatment in clinic. How do you imagine clinics may adapt and change for this? I can imagine because it's a new innovative treatment, never been seen before, it's going to require quite a lot of change from the healthcare practitioners, the hepatology departments, to ensure that they select the right participants and tailor the clinic around people who will be on the functional cure.
So are you asking me or Patrick?
Both of you.
Thank you. You go first.
Sorry, can you just repeat that last bit of the question again?
Of course. How would you expect the clinics, the liver clinics to change here once bepi is approved? Would there be any changes to how clinics might work, or would it be like a private, will be a separate clinic for people who will be on bepi only?
Well, I think every clinic is going to be different. Every hospital is going to be different. The logistics of bepi during the clinical trial were quite challenging, I should say, because it required patients to be tested same day and results same day before injection. Now, a lot depends on the guidance by the FDA and the European Medicines Authority. They will provide guidance on the frequency of monitoring and which results you can use for injection. For instance, if they require same-day testing and monitoring, it will be a really big challenge because you can imagine if you need to do kidney function, ALT, and your platelet count, and you need to have the results before injection. If the hospital's turnaround time is 3-4 hours, you don't want people sitting around 3-4 hours waiting for their results before injection. So this could be a real problem if the authorities request that. My own sense is that they may be willing to accept the previous week's results. So you have tested the previous week, and it looks okay, you can come in and the doctor will check the results. You have your injection straight away. So pretty much you could be in and out in half an hour. Of course, that's assuming that the time to see the doctor is pretty minimal. But so if you have a very busy clinic and you have a mixture of patients who need to be seen for other reasons other than bepi, then the waiting time becomes the main issue. I think this basically reminds me of the time of hepatitis C, where patients need to come in for interferon injections. And there were actually practice nurses who were delivering most of the injections and monitoring the patients. So that one could actually be very effective way to manage patients without having to clog up the normal clinics and have to see the doctor. So the doctor would pretty much check the patients at the first visit, say, yeah, you're suitable for therapy. They explain all the side effects, you understand all that, put you on to the practice nurse who would then manage the logistics of follow-up, bepi injections, and the monitoring process. To me, that would seem to be a much more streamlined process, and I suspect a lot of hospitals will be doing that.
Yes,
Thank you,
super. I completely agree with Sengi. I think he's covered it very nicely and gave a very elegant talk around bepi. So I think that really does cover. I think that certainly giving a UK perspective, the changes that we've had around hepatitis C, I think we will use the capacity there in terms of clinical nurse specialists to support bepi. And I would imagine that a combination of using those existing resources and ODNs that will try and set up dedicated bepi clinics within the standard clinics, and that will really just be focusing on trying to get as many patients access to this new therapy as we possibly can in the safest, the most effective way. So it'll be about a little bit of evolution about how we deliver our care, but it will rely largely on the infrastructure and the expertise of the existing clinical teams. So I'm very confident. I'm like Sengi. I think we will develop strategies to be able to do this and to be able to allow our patients to get access to this new therapy. I think that's critical.
Cool. Thank you, Patrick. Thank you. We had one last question come in for this section, and then we'll move on to you, Patrick. So we have a question from Kun Sulapong. How about the rate of functional cure with bepi between Asia compared with Hispanic or African chronic hepatitis B patients?
Based on the data, and I didn't show this, but the efficacy of bepi seems to be quite good across all regions and ethnic groups. There are differences in efficacy, and this was mainly related to differences in baseline characteristics between the patient populations. So there weren't any specific identifiers that could change expectations with regards to ethnicity. However, the group that's older than 65 didn't seem to do as well as the age group below 65. So that's something to think about. Yeah, we don't have a lot of data and details about the differences in these two age populations, and I suspect that we'll have more data coming up to the AASLD meeting in November, end of the year. So we might get more clarity on that.
Perfect. Thank you. Well, thank you. Okay, we can move on to the other side of the equation today. Patrick, hepatitis D remains one of the most challenging conditions in hepatology, severe disease, limited treatment option, and well, maybe not so much now, but historically very little in the pipeline. But EASL has shown us a couple of results on this front. And also, in recent years, we've had Brelovitug being available in most of Europe, and I think as of recently, America as well. So, Patrick, over to you.
Thanks, Supa. Very kind of you. It's a real pleasure to be here and to share this platform with Seng, of course, and others. I think this is really an exciting time. I think Seng has shown us really the huge progress that we've seen in hepatitis B. But similarly, and maybe even more marked, is the progress that we're seeing in hepatitis delta virus. So today I'm going to focus on just a couple of studies that were presented at EASL and cover some of the data from there to see the progress that we're making in probably what we all recognize as the most severe form of viral hepatitis. I'm starting with the SOLSTICE study, and this is the combination therapy, really, if you're looking at the blue panel here, the combination therapy of the monoclonal antibody and siRNA, as I'm showing you here. And this is data that shows the 96-week follow-up data of on-treatment patients. And this, of course, follows on from the seminal New England Journal paper published last year on this combination strategy. What I want to show you, and I'm going to keep this very much an overview for people so they can see. In hepatitis delta, for many years, we've had no effective treatment at all. And more recently, we've had the emergence of Brelovitug, and this was available firstly in Europe. Now the FDA have approved it, so it's now available globally. But what I want to show you here is the kind of direction of travel that we're seeing with some of these newer drugs. And these are phase 2 data from VIR. And what I want to show you here across this response is, if you look at viral response for this combination therapy, the combination therapy is shown in dark blue. The monotherapy with the monoclonal antibody Tobevibart is shown in yellow. What you'll see here is you'll see the viral response of 88%. And as we move out with that, that's a target not detected of 88%. So what these drugs are doing is they are providing profound viral suppression. And that's important. I'm going to come back to it again a little bit shortly. And then if you move further along this data, looking at ALT normalization, we're seeing it at 63% in the monoclonal antibody and 53% in the combination monoclonal antibody and siRNA. And then if we look at this combined response, that's HDV RNA target not detected, so that's undetectable viremia plus ALT normalization. Again, you can see this is being achieved in over 50% of patients at 96 weeks. Let me draw your attention now to the data shown here on the right as we look at this. As you move out from 24 to 48 weeks to 96 weeks, you are seeing a continuous augmentation in that target not detected with the combination therapy. And that's really critical because we think this target not detected may be opening up the possibility of finite therapies, which I'm going to come back to a little bit later in the presentation. Another really important thing, of course, that we're seeing with these combination strategies with the siRNA monoclonal antibody is this level of surface antigen suppression. So you've just had Seng talking about functional cure and surface antigen loss. We saw that's impressive with the bepi data, up to 26% in that surface antigen less than 1,000 IU group. But what we're seeing in delta hepatitis is that we're seeing a very robust suppression of the surface antigen, which is actually happening at a very early stage with these combination therapies. Almost 90% of individuals achieving a surface antigen titer of less than 10 IU at 24 weeks, which is maintained as we go out. These are really, really striking data because this is taking us from where we were unable to suppress virus, we were unable to normalize ALT, and where we were having no effect on surface antigen, largely as you would see with Brelovitug, to achieving almost all of these with this combination approach. So what I'm doing here is I'm showing you this blue box as a kind of take-home summary, which we used at our IHEP meeting. And essentially, this is some summary bullet points for you. And that is, at 96 weeks, combination therapy achieved high rates of HDV RNA target not detected, reductions in ALT and surface antigen, and this was all very well tolerated throughout the course. ALT normalization was similar between the monoclonal antibody and the siRNA and monoclonal antibody combination. Tobevibart and Elebsiran, that's the combination, rapidly reduces surface antigen less than 10 IU in approximately 90% of patients. So, as I said, this really raises the possibility for potential finite therapies using this combination strategy as we move forward. A question for the field will be, what will determine this finite therapy approach? Will it be HDV RNA target not detected? We think the earlier that you achieve this, the greater you have the potential for this sustained response. So will this be, if you want, a signpost for finite therapies and potential curative therapies? This remains to be seen and will be addressed in the phase 3 studies. Significant reductions in surface antigen, but again, going back to Seng's presentation earlier, the fact that that surface antigen persists, will it remain an issue in delta hepatitis? This remains to be seen. So we're making big progress with these data, but there's still some unanswered questions that we'll address as we go forward. The next data I want to show you is the formerly Blue Jay monoclonal antibody. This is the AZURE-1 study. So Blue Jay has now been taken over by Mirum Pharmaceutical. So these data were presented by Mirum Pharmaceuticals at EASL. And really, you can see the setup of this study. Again, very straightforward. Look at the inclusion criteria. These are all patients with detectable HDV RNA. All individuals had to have a Child-Pugh score of less than 7, all of them willing or taking nucleoside-nucleotide analogues. So any hepatic decompensation or HCC would be exclusionary in this study. What we're looking at is the Brelovitug 300 milligrams once weekly dose at home versus the Brelovitug 900 milligrams once monthly dose. And keep those once weekly versus once monthly dosing in mind, because we're going to talk very briefly about bulevirtide. And then there's a delayed treatment arm just as a comparator. But let's move forward quickly, give you an idea of the makeup of these individuals. So look at across the top line, N equal 21 in the 300 milligrams once weekly dose, 900 milligram once monthly dose, N equals 20, and then the delayed treatment, N equals 12. Just drop down here to look at approximately 50% of these individuals are cirrhotic, a combination of Child-Pugh A5 and A6, and you see the liver stiffness measurements here. And in the Blue Jay Mirum study, we've even had some inclusion of E antigen positive individuals. Now I'm going to show you the results. So again, look at the delayed treatment shown on the top of both of these in terms of HDV RNA reduction and ALT normalization. The delayed treatment, exclude that. Now look at the dots representing the 300 milligrams once weekly and the squares representing the 900 milligrams once monthly. You can see a faster and probably more dramatic reduction in HDV RNA with the once weekly dose. That's an important observation. The 300 milligrams once weekly versus the once monthly dose. Look at ALT normalization. We're probably seeing, again, certainly a steeper reduction in ALT with the once weekly dose compared to the once monthly dose. And they seem to plateau as we get out to about 24 weeks. In the delta hepatitis field, there's a lot of talk about what these drugs are doing beyond the virological and biochemical response. And these are data showing reductions in liver stiffness. Now, personally, I don't read an awful lot into this. We're interested to hear what Seng has to say. But in my opinion, what you're seeing at this week 24 data is really a dialing down of the inflammation. And as a consequence of dialing down of that inflammation, normalization of ALT, you're getting reductions in these FibroScan scores. I don't personally think this is reduction of fibrosis or regression of fibrosis. And we'll come back to that. Moving forward to the blue box, the take-home points that I want to show you, that I want you to kind of think about as this webinar ends. Brelovitug, a monoclonal antibody against HBs, confers marked suppression of HDV RNA with frequent ALT normalization. The dose of 300 milligrams once weekly appears more potent than the 900 milligrams once monthly dose. Higher rates of HDV RNA with a greater than 2 log decline. higher rates of lower limit of quantitation or target not detected, which we think is really important in the context of treatment of delta hepatitis. Potential reasons for superiority of the once weekly versus once monthly. Well, cumulative dose would appear to be higher if you're taking 300 milligrams once weekly versus 900 milligrams once monthly. There seem to be no apparent disadvantages in terms of safety between dosing. So if you were dosing at home once weekly, you're not in more harm's way than if you're having once monthly dosing in the hospital or in the clinic. In the real world, what would the preference be? I think it's likely to be the preference would be once weekly dosing at home. Word of caution in terms of our interpretation of this early reduction of liver stiffness. Personally, I think this is a reduction of liver inflammation rather than fibrosis regression. Long-term data on sustained response, clearly this will be eagerly awaited, but these are very, very promising data, and specifically in the context of this rapid reduction in the HDV RNA to a lower limit of quantitation or target not detected, because we think this is a key metric as we move forward over the longer term. Now, what's available in the clinic now? I've just shown you the 2 new drugs which are in phase 3 trials. In the clinic now globally, you have bulevirtide. And how do we interpret bulevirtide? Well, you know, we've had building up data for over 4 years, and this is the SAVE-D study presented at EASL, which is a data from 65 centres across Europe, Romania, Switzerland, even Canada. So more broadly giving us a greater interpretation. I'm not going to go into the baseline characteristics, but I'll draw your attention to that you can see here that even in this group of treated patients, 7%, almost 10% had a history of HCC, almost 10% had a history of decompensation. Sick patients accessing bulevirtide. What are the responses? Well, you can see, very interestingly, as you move across from 48 weeks to 96 weeks to 144 weeks to 4 years, you are seeing gradual improvements in green in virological response, in blue biochemical response, and in terms of the combined response. The longer you're on bulevirtide, the greater your chances of achieving improved responses. Now look at the 4-year cumulative incidence, and I'm showing you virological response, biochemical response, combined response. These are impressive treatment responses in such sick patients. And I think that's a really, really key take-home message for us. That from just a few years ago, where we didn't have a treatment for delta hepatitis, we now have treatments. We're seeing excellent responses, reductions in decompensation events, really good baseline. But I think anybody will say to you the bulevirtide once daily dosing is a major limitation for our patients, for people living with delta hepatitis, that you have to essentially inject yourself on a daily basis. And at present, that's an indefinite treatment approach. So in summary, the treatment landscape is evolving in delta hepatitis, and it's evolving with speed. I think we are in a very different place where we are today than we were 5 years ago with delta hepatitis. I think the new treatment options, Vir's combination approach, siRNA monoclonal antibody versus Mirum's monoclonal antibody, these agents are now in phase 3 studies, and we're going to be seeing readouts over the next couple of meetings as we move forward. What's the comparator? The comparator is bulevirtide. It's established itself as a very safe, very effective drug, which is widely available as a first-line treatment strategy. Will it remain there? Will we be able to use bulevirtide and achieve treatment cure, which I'm referring to here? Because emerging data would suggest that finite therapies and cure is a realistic therapeutic target. And it is, because the earlier achieve HDV RNA undetectability, target not detected, this seems to infer some concept of sustained response. But we need to see these replicated, validated in bigger data sets, which I'm sure we will see over the coming years. But from my perspective, this is really, really exciting data and a really exciting time in the delta hepatitis space. Thank you very much.
Thank you so much, Patrick. It gives me a little bit of goosebumps knowing that hepatitis D a couple of years ago would have essentially I don't want to say a death sentence, but that's what a lot of my community members have told me previously. And now there's so many new treatments coming out in the field, and especially with the combination approach, and then even the move, because I used to work in the HIV space, and going from tablets, daily tablets, to long actings to injectables, it's surprising to see that we're going from essentially interferon to Brelovitug, which is once a day, to Brelovitug and other treatments where it could be weekly, which is absolutely crazy how everything is developing so quickly. So I will give some time for people to put questions in the chat, but for the time being, I'll go back to Chirag's question that he put out earlier on. Chirag is in Southeast London in hepatology. They ask if you can suggest to continue entecavir for hepatitis B treatment whilst on Hep D therapy.
Oh yeah, I think right now, the what we want in this sphere is we want consistency about what we're all doing and what we're saying and how we manage individuals living with delta hepatitis. So absolutely, my advice is when we get people into the clinic, new diagnosis of delta hepatitis, we will put them on an antiviral, get them started on an antiviral therapy. For many of these clinical trials that I just showed you for both Vir and Blue J, now Mirum, there was individuals were mandated to be on antiviral therapy with a nuke before going on to the IMP. So these are key things, and I think for consistency, I think it's important. Interestingly, in the real world data presented at EASL, about 10% of individuals were on bulevirtide but not taking a nuke. But there's no good evidence that we should not be giving a nuke. And the greater majority of evidence certainly sits with individuals being on nuke before going on to the delta hepatitis treatment.
Cool. Thank you, Patrick. And you've your last key takeaway on the last slide really took it away from me because with hepatitis B, we are coming almost towards a cure now, at least for a certain percentage of the population. But now we're looking at finite therapy of hepatitis D, which is also mind-blowing to me. So we've seen now with Brelovitug, that's 4 years, 4 years on Brelovitug has caused almost a finite treatment for hepatitis D. Are we potentially seeing this with the with the Mirum and the Verbio one as well? Is it something which, are they similar mechanisms of actions, and is it something that we could see in future?
I mean, that's a really good question, Supa. While they're not the same mechanism of action, there are some similarities. I mean, the difference with Vir is that it includes an siRNA, and that's in combination with a monoclonal antibody. And then you've got Brelovitug, which is a monoclonal antibody against HBs. So you could loosely say that there's some similarities between the entry inhibitor bulevirtide with the monoclonal antibody, but just some. I think that what I think is emerging across all of these agents is the faster that we are seemingly able to achieve viral suppression with this drug, be it bulevirtide, Brelovitug, or the combination siRNA monoclonal antibody of Vir. The earlier you are achieving this virological suppression, target not detected, very, I would say, very robust viral suppression. This is clearly giving us some insight into individuals who have a more sustained response. Do we want to use the word cure? I think it's a bit premature, but I think if you are optimistic, yes, we would be talking about cure, because that's actually what we're seeing. And we also saw some data around stopping treatment with bulevirtide successfully. And in the phase 3 studies of Vir, they have included a stopping rule or stopping arm to see, is it going to be possible to achieve that finite therapy with these new agents. So definitely there's a lot of optimism around this. It's interesting, and we can talk about it a little bit at length or discuss it further, but what is the key metric which would determine stopping therapy? Would it be surface antigen, which is less than 10 IU and maintained at that very low level, or is it the target not detected and a more protracted period or prolonged period of target not detected of HDV RNA? We don't know the answer to that, but I guess, the more security we have in interpreting those markers, be it very low levels of surface antigen, ideally surface antigen loss, a little akin to functional cure in hepatitis B, clearly that's providing us with a greater safety net, I think, in delta hepatitis. But still, massively exciting time for me. And we're going to understand this an awful lot better over the next 6, 12, and 18 months.
Cool. Thank you, Patrick. It doesn't seem like we have any other question for hepatitis D, but there was one more on my list I wanted to ask. You mentioned something about ALT normalization as part of the composite endpoint. From a patient's perspective, what does this actually mean for the patient? Does this mean that they will be feeling better? Would that mean, I guess, I'm thinking more of quality of life, any kind of symptoms that might come of hepatitis D and all that?
Look, that's a very good question, Supa. I think that all of us, I think Sengi and I would agree here that, if we can turn off the inflammation in the liver, we think, one, we're helping our patients that there's not ongoing inflammation. We're all familiar with that paradigm of inflammation leading to fibrosis, fibrosis leading to cirrhosis, etc. So turning off that inflammation, I think, is a key aim. We would expect that individuals where the ALT has been normalized would feel better. We would expect in terms of better disease outcomes. So I think it's very, very important. There's still a lot of debate in the field about that ALT normalization. Why there's some persistent ALT perturbation. But remember, delta hepatitis is a very inflammatory virus, an inflammatory hepatic milieu with a lot of inflammation and aggressive inflammation. So I think over time, any turning down of that inflammation, improving of that ALT is leading to improvement in the disease outcome. I think that for me is very clear.
Thank you, Patrick. Okay. I don't think there's any more questions. So thank you both. This has been a wonderful webinar and a great note to end on. We seem to have been having great developments in both hepatitis B and hepatitis D. And thank you, Patrick and Sengi, for your generosity with your time, and your expertise today was highly appreciated. And for everyone who's joined us today, whether you are a doctor, healthcare worker, researcher, someone affected with hepatitis B and or D, thank you for the questions that have come through. Chirag asked, would you be sharing the slides? Is that okay with both of you, Sengi, Patrick?
I'll send you the slides later on.
Absolutely.
Sure thing. And then
Absolutely.
we'll circulate it to the people who have come in today. And I guess one last note, well, two last notes on me. On behalf of the whole team, our colleagues at the BBHD, the British Viral Hepatitis Group, thank you for being here today. Looking forward to see you at the next one. And for the people living with hepatitis B, hepatitis D, we have hope. We are moving in a great direction. There are great treatments potentially coming out. And just a little plug for myself. If you haven't seen the HepB and Me app on the App Store yet, please take a look at it. It's a very, very good app to help you track and give you information on hepatitis B and D. It should be available on iOS and Android. But thank you all, and have a nice afternoon/evening, everyone.
Thanks, Supa.
Thank you so much,
Sengi.
Supa and Patrick. Great
Thanks.
to talk to you and participate in this lovely webinar. All the best.
Great
Thank you.
seeing everybody. Thank you.
Thank you,
Bye.
everyone.